Hello again. The lighting is still terrible on this thing, but I think we'll just roll with it. Welcome to week whatever this is. We are on chapter 9, which is sexual disorders. So that will be our topic of the evening. Hope all of you are doing well. This weird thing has continued to get weirder. I've now tested positive for COVID-19, so I'm I have sore throat and kind of feel crappy, so I'm still going to try to get through this tonight, but if I can't do it in one session, I'll do it in 2 different ones, but I'm going to try to just knock it out. So hope all of you are doing well and staying safe, and I honestly have not spent a lot of time thinking about assignments and what have you this week, so I'll have to take a look at the syllabus and see what's upcoming, and I'll figure that out in the next day or 2, but I did want to go ahead and get this posted. So in terms of assignments or what's coming next, I know we have an exam coming up, but I'm not sure if that's next week or the week following, but I'll post some more information about all that just so you all know what to expect. But that next exam will be much like this. The next exam will be much like the one we had before, same format, roughly the same number of chapters, so it'll be very similar. But tonight we're talking about sexual disorders, so without further ado, I'll get into it. When we're talking about this section, this, I just want to go back for a second to the conversation about the first week of class. And the difficulty of determining what's normal versus abnormal. I think in some of the sections that we talk about, this is more apparent than others. And in this chapter, it's really important to take a look at what is normal sexual behavior versus what is abnormal and who determines that. Largely what we're going to be talking about today are sexual disorders that are identified in the DSM as being abnormal, but also keep in mind that in order to be a disorder, it has to cause significant impairment, it has to impact your ability to function in your daily life, it has to be something that is problematic enough that it affects your home life, it affects your job, it affects you in some meaningful way, and it is deemed to be abnormal compared to other people around you. So, but it has to have some sort of dysfunction. So the big argument here is, well, what about people who just like things that some of us may find abnormal in their sexual life, but it isn't deviant to them, it isn't unusual to them. Over the last, I don't know, the 50 Shades of Grey effect, we've had more sort of open conversation about like BDSM lifestyles. And so that's an example. Is that something that is deemed to be deviant or abnormal? Is that something that is okay? Is it acceptable? And I think the answer to that question depends on a lot of different factors. Number one is sort of a personal preference, but in terms of disorders, it's not really a disorder until it's causing all of those problems, until it's causing that harmful dysfunction and that impact on your everyday life. So keep that in mind as we're going through, and I'll bring that up again. We'll talk about it again, but what is normal sexuality is very important here. So we'll talk about sexual dysfunctions, which is also part of this section, paraphilic disorders. We'll talk about gender dysphoria a little bit. Some of the questions that we'll talk about is, how do socio-cultural factors influence what is normal in terms of sex? Normal sexual behaviors really are dictated a lot by our culture. As much as by anything that we're talking about here, in this class, the sexual behaviors are something that are very tied to cultural norms, and can vary wildly depending on culture. We'll also talk about how psychologists are going to define sexual dysfunction. Is that a medical issue? Is it a psychological issue? In fact, it generally is both. We'll talk about some treatments. I don't want to spend a terrible amount of time on that, but I think it's worth mentioning because it is such a kind of a huge issue. And we'll talk about what we know about paraphilic disorders and just some of the, we'll touch on gender dysphoria a little bit. So when we talk about what is normal in terms of sexual behavior, we look at research, we look at statistics, we look at cultural considerations, we look at differences between the sexes, differences between the genders, I should say. So when we're talking about what is normal and abnormal, it's important to know what most people are doing. So your textbook has some graphs about like most common types of sexual intercourse by age, by gender, and you can take a look at those. I will post the PowerPoint slides, and like you go through, and I think this is like the 5th slide. There's a graph that looks at percentages of males, and then another graph, percentages of females 15 to 24 who have had vaginal intercourse, and percentage who've had oral sex but not vaginal intercourse. So I think it's interesting to look at sexual behaviors of sort of the young adults, late teen young adults, to try to get an idea of how that compares to the general population, then look at sort of each age cohort as you go through, and you can look at the differences there. And then also it looks at different types of sexual contact amongst the different age groups. And this particular chart goes 25 to 44. So kind of look at that middle, not mid-adulthood, but sort of, I guess, young adult to mid-adulthood, that age range. So the 25 to 44. And you can see if you look at that graph, 98% of the people in that those age ranges are sexually active, and let's say 90% roughly in both male and female are having some oral sex contact with the opposite sex. Similar numbers for vaginal sex, vaginal intercourse with the opposite sex. And then anal sex is right at like around 40 or 35%. So it just gives you a good idea of what types of things people are engaging in. And so when we're talking about what's normal and abnormal, it's important to know what people are doing. And so we would not find any of those things to be abnormal, given that such a large section of the population is engaging in that. So I hope that makes sense in terms of trying to figure out what is normal. If we said, if you just think about general population, if you say there were only 5% of the population engaging in vaginal intercourse, that would make that abnormal behavior. But when we're looking at things that, at least that 90-some% of the population are engaging on, then we'd have to consider that to be normal behavior, which we all know. We all, we know just from our own lives that is not. None of those things are abnormal in terms of sexual behavior. When we're going through later, we'll look at some of the more deviant behaviors and talk about how we break that down. But when we're looking at the most normal of sexual behaviors, those are generally the ones that we're talking about. So let me see. I have gone too far. Okay. So the first part that we'll talk about is sexual dysfunctions. Problems arise with sex. We know this because we watch TV and we see all of the commercials. There's always commercials about sexual dysfunction. And we'll talk about some of the different things, but essentially what this is problems with desire, arousal, or the ability to achieve an orgasm, or pain. Problems in any of those areas are what make up sexual dysfunction. So in sexual dysfunction, we're not talking about like paraphilias. We're not talking about like things like that. We're talking about the inability to engage in sexual behavior as you would normally do so. So, and in order to have sexual dysfunction, it has to be ongoing, has to be over a long period of time, generally a period of time that lasts 6 months or more, and it has to cause problems. It has to result in significant impairment and distress. So again, keep that in mind when we're talking about what it is that we're talking about here. So how often does it occur? Again, remember, we're always looking at how frequent things are. Sexual problems are very common, and they're not distressing in the same way to everyone. The study your book cites says 40% of men had some problem with erection or ejaculation. So that's a huge number of men, 40%, probably underreported. 63% of women had problems with arousal or orgasm. Again, probably underreported. Here's the thing with sexual dysfunction, much like drug use, even self-report that is anonymous doesn't tend to be reliable. So it isn't always the case that the information we're getting is entirely accurate. Generally, if you want accurate information, you can ask people to answer anonymously, and they will give you a pretty accurate representation of the problem. There's a couple of areas that doesn't work: sexual dysfunction or sexual behavior in general, and also drug and alcohol use or illegal activities in general. And some of these tend to be underreported, or in some cases overreported. With substance abuse, college students tend to overreport substance use, whereas the general population tends to underreport, even with anonymous surveys. So it isn't always reliable. We don't get the best of information, but you can figure out around half the population, male or female, some a little more, a little less, are having problems with sex in some way, ongoing for 6 months or more. Doesn't mean it's a lifetime thing. It just means at some point in time. And males and females experience parallel versions of the different disorders that we'll talk about. So just some of the different things to keep in mind. Some of these are lifelong problems, and some are sort of acquired problems, can be situational, and some are more generalized over different settings. Some are psychological alone. Some are a combination of psychological and medical, and we'll talk about some of those. The first one we'll talk about is essentially disorders that result in the lack of sexual desire. In males, that's male hypo or active sexual desire disorder. I made a mess of that. Male hypoactive sexual desire disorder. Hypo meaning there is an issue with your desire. Hyper sexual desire would be too much, right? If you have a hyper desire, you have sort of an overactive sexual desire. So this is the opposite of that, hypoactive sexual desire. So little or no interest in males. This is a little or no interest in any type of sexual activity. Not only intercourse with another person, but little or no masturbation or any sort of sexual fantasies. There's just no sex drive there at all. This accounts for about half of the complaints of sexuality clinics, or people are going to the doctor for problems. Just, hey, I have no sexual desire. And this can be very problematic, particularly in a culture that places a lot of emphasis on sexuality, right? It affects about 5% of men, so relatively small number. But again, all of these things are probably underreported. And you can look at the DSM criteria there: persistent or currently deficient or absent sexual thoughts or fantasies. And this is causing a problem, and it's ongoing for 6 months or more. And then the female version of that, female sexual interest or arousal disorder, is lack of or reduced sexual interest or arousal, usually occurring in much the same way as it does with men. reduce sexual interest, reduce sexual activity, reduce thoughts about sex, and reduced arousal to sexual cues, and reduce pleasure or sensations during most sexual encounters. It's we can talk about this we'll talk about it now since we're talking about it, but one of the differences here is that men who are having sexual arousal disorder, they are unlikely to even be able to engage in sexual intercourse. The same is not necessarily true of women. And so often what you have here is women who are having sex but not getting any pleasure or not having an interest in it. So reduced pleasure sensations during things that would normally be arousing for them. Generally with men, they avoid the sexual contact altogether. So there's a little bit of difference in terms of the difference between the male and female response to this. But the long and short of it is that there is no interest and no pleasure derived from the act of sex itself. And you can look through the DSM criteria. I'm not going to read those to you. But again, this is ongoing. This is something that's going on for 6 months or more, and it causes a lot of stress. The female orgasmic disorders, the next disorder we'll talk about. This is a delay or decreased intensity of orgasms, or just not being able to achieve an orgasm. So, and this is not explained by stress in the relationship or any other kind of stressors that could easily explain the reason for not being able to achieve an orgasm. This is simply the inability to easily or achieve orgasm through sexual intercourse. 1 in 4 women have problems with this. Probably, again, that's an underestimation. Who's collecting this information? A bunch of guys. Like what do we know, right? So the 25% is probably a low estimation of the amount of women who are actually experiencing problems with this. So again, and this is in almost all or all occasions. So people who are just sometimes having issues, occasionally having issues with not having an orgasm, that is not what we're talking about here. This is prolonged, and it's usually over many years, different partners, that sort of thing. If it were tied to a specific partner over a limited period of time, you could probably attribute some of that to maybe that particular relationship, but this is a more ongoing, pervasive issue. And also just the reduced intensity of an orgasm if you actually do have one. So, all right. And also there are, I mentioned for a lot of these disorders, there are male and female equivalents. That's one that doesn't have a neat and clean male version. Also, this one doesn't either. The pelvic pain penetration disorder, essentially pain during intercourse that happens most of the time that sexual intercourse is happening, pain during intercourse or attempted penetration, and it often makes women want to avoid sexual activity, obviously, to avoid pain, but also a lot of fear and anxiety that are related to having intercourse because they're worried about the pain. And essentially what you have is tensing of the pelvic floor muscles and anticipation of sexual activity, which, if you think about anxiety and how that works, your body misinterprets signals that are going on. And so that tensing of the floor muscles in anticipation can also trigger some anxiety in anticipation of sexual contact, which can create a lot of discomfort and lack of interest. So it's kind of this downhill spiral. Let's see. And again, another 6-month long-term disorder. Then we'll switch over to problems that guys are having. Premature ejaculation. You all heard that. The sexual enhancement world for men is a lot more prevalent than for women. So You have commercials and ads. Listen to sports radio on the way to work in the morning, and I guarantee you, in my 20-minute commute, I will get at least one, probably multiple ads for either erectile dysfunction or premature ejaculation. And so, like, this stuff is out there. We all know about this, but what that is essentially is ejaculation occurring in less than a minute of penetration and before it is desired. And it is the most prevalent sexual dysfunction in men, followed shortly thereafter by just erectile dysfunction. 21% of adult males. This is most common in younger, less experienced guys and tends to decline as you age. So one of the few perks of aging is that this tends to reduce in likelihood. The flip side is symptoms of erectile dysfunction sort of follow the opposite trend and tend to increase with age. So you have less of that particular problem and more of the other. So again, it's generally ejaculation in less than a minute of penetration and before it was intended, going on for a period of 6 months or more. So it's not a situation where it happens a time or two. This is consistent most of the time that you're having sexual intercourse. So very common. And 20%, that's a fair amount. But again, keep in mind, this isn't something that is happening across time. This is often episodic, and people, as I mentioned there, as you age, this tends to happen less and less, and also is more prevalent amongst people who are experienced. So it is something that a lot of guys can work through without therapy or any kind of issue on their own. So erectile disorder, erectile dysfunction is also something that we all know about because of the commercials and the availability of medicine and how prevalent that world is. Erectile disorder is the difficulty maintaining or achieving an erection. The sexual desire is intact. Essentially, the desire is there. Your body is just not cooperating. And it is the most common problem for which men seek treatment. I mentioned that premature ejaculation is the most common in existence, but people don't often seek treatment for that. But people do seek treatment for this, and the reason is that there are medications for it. There's a way to treat it. Prevalence does increase with age, so 60% of men over 60 experience some sexual dysfunction. So more than half the population. There's a little graph. It is on the slide, it's number 27. In your book, it's like figure 9.3. It looks at the occurrences of erectile dysfunction by age. So in 40-year-old men, complete, which means every single time there's no ability to achieve or maintain an erection, that's only about 5%, a little less than 5%, whereas you have moderate impairment and minimal impairment roughly looks like 13-14% of the time, and then no problems for 60% of the guys, and that prevalence increases with age. The complete dysfunction creeps up there. The blue lines, which means moderate impairment, increases. Everything increases except for no problems at all, and then that decreases. So it is very obvious the differences in terms of age. So that's primarily the dysfunction section here and what we're talking about. When we're talking about assessing sexual behavior, how do you do that? That's a little more complicated. The key here is getting a comprehensive review of sexual behavior, lifestyle, stress, any other factors that may be playing a role, relationship issues, and also medical examination. A lot of this is done in the medical field. This isn't something that people are typically going to come to a person like me for. You're probably going to come to a psychologist or a mental health professional after you've been to a medical provider, because we just generally think of these as being medical disorders. They have a psychological component as well. but it's very much a medical disorder that has a very prominent psychological component, if that makes sense. So your first rule of thumb is going to be ruling out any potential medical causes. With many of these things, they're particularly with like erectile dysfunctions and even a lesser extent, like, well, not even a lesser extent, like the female orgasmic disorder, tend to be blood flow issues, right? Like whether or not there's also psychological involvement, that's a different story. But also we have psychophysiological evaluation. And if you want like a recommendation of a good place to go to look at some of this in action, the Showtime series Masters of Sex, it's the Masters and Johnson studies from 1950s or 60s. But they did a lot of the psychophysiological evaluations, essentially connecting people to electrodes and measuring the physiological responses to erotic materials or to sexual activity. You see a lot of this. Just a fair warning, predictably, it's a adult-oriented thing. It's on Showtime. There's nudity, there's language, that sort of thing, but that is also pretty much what you would expect. But if you want a sort of a well done look at how that works, that isn't necessarily like too graphic, I think it is something that will give you a look inside of like what it looks like to study that. And I can't imagine how awkward it would be to be engaging in that sort of research, but Masters and Johnson were sort of the cutting edge, and still in the times we're in now, one of the few researchers they were definitely pioneers, but a lot of what we know currently still comes from the research that they conducted. Probably them and Alfred Kinsey at the Kinsey Institute are why we know what we know. But a lot of this was through some of the psychophysiological evaluation. So they would, in essence, hook you up to heart rate monitors or monitors that monitored the arousal and stimulation in your sexual organs. And they would do this in exposure to erotic material, whether that be in print or video or like people talking or reading or what have you. So this was done to sort of give a measure of the sexual response. This is how we know what we know about sexual response cycles and orgasm cycles and things like that. So we gathered a lot of information through studies such as that. A lot of what we know, we lend to that. In terms of causes and treatments of the disorders, there is both the physical link and the psychological. So the physical disease, you can actually have disorders that cause problems with sexual response. Heart disease, diabetes, high blood pressure, obesity, all of those things can cause problems in your sex life. Also, responses to prescription drugs. What's one of the more common responses to antidepressants is having sexual dysfunction, but also other drugs too, blood pressure medications, again, medications for diabetes and heart disease, and all of those things can lead to some impairment in sexual functioning. Drugs and alcohol can play a role. Alcohol is a depressant, so it will cause problems in your sex life. That much is very well known. Things like methamphetamines can cause sexual impairments. A lot of drugs, and alcohol being one of them, in like the short term may feel like it enhances your sexual desire because it decreases your inhibition, but over time it does cause a drop in the ability to engage in sexual behavior, and will ultimately cause significant impairment going kind of long term. And also medicines taken for hypertension also cause sexual side effects. So In terms of psychological contributions, people with sexual dysfunction are more likely to experience anxiety and negative thoughts about sex. So the more anxious you are, the more negatively you think about sex, the more likely you are to have problems. And it becomes this vicious cycle because you have trouble achieving an orgasm, you have trouble achieving an erection or maintaining an erection, and it causes all this anxiety that it's going to happen again. And it's one of these things that increases the likelihood that it's going to happen. If you worry about sex enough, it will essentially create on its own sexual dysfunction and make it less likely that you'll have success. So a lot of people will actively avoid having sex for fear of having the problems that they associated with it, and just avoiding sexual cues. They're not really in response, and sometimes people aren't in response with their own bodies. They aren't in response to their own sort of sexual response. So it creates problems in and of itself, just the anxiety, the psychological component of struggling with sex. And some sociological, cultural factors. We mentioned this is we have a lot of negative attitudes in our culture about sex and sexuality in general, particularly towards women. There's a lot of negative stereotypes that come along with sexuality. And we all know there is a double standard that follows that. And you know, you all have lived that. I don't have to go into great detail about it, but it certainly exists. Also, people have traumatic experiences related to sex. That plays a role as well and can cause a lot of problems in the sexual response. It can cause problems in future relationships. It can cause a lot of problems in this particular area. Also, as relationships start to erode and as interpersonal difficulties start to arise, you'll see more sexual dysfunction in that particular relationship pop up. That's why I mentioned before, sometimes this is kind of situational and isn't generalized. It's just particular to that one relationship or one situation. So you have to keep an eye out for that. As your relationship starts to erode and as communication starts to suffer, you will see more sexual dysfunction. In terms of treatment, education alone can be very effective. The fact that this is normal, just connecting the dots that anxiety and stress can cause a lot of problems with sex, just connecting the dots that this medication you're taking is making it more difficult for you. There isn't anything wrong with you. This isn't abnormal. It just is the way your body works. That can actually have a really positive effect for a lot of people. And then some of the stuff that we learned from Masters and Johnson and their studies, the psychosocial interventions, like educating about the importance of how the sexual response cycle works. It's not just a 0 to 60 and immediately. The importance of foreplay and sort of pleasure without demanding, immediate gratification and orgasm. So sexual activity, also sensate focus was one of the things that they talk about, the sexual activity with focusing on pleasure and sensation without the pressure of having an orgasm. So it's one of the things that Masters and Johnson found effective. It also is successful in decreasing performance anxiety because the focus goes off having an orgasm into achieving pleasure, reconnecting with your body and trying to figure out what feels good, what doesn't feel good, what you like, what you don't like. So all very important things. A lot of other psychosocial procedures, again, that we primarily learned through the likes of Masters and Johnson and Kinsey, using various techniques, the squeeze technique to control premature ejaculation, masturbatory training for the female orgasm disorder, just sort of teaching, getting used to achieving orgasm, figuring out what you like. Also exposure to erotic materials for people who have low sexual desire to see if that will jumpstart things. So, but by far the most common treatments that we use are medications, particularly for erectile dysfunction. There's a handful of medications out there that we all are familiar with, primarily Viagra. Viagra is like the magic drug of the 21st century, 20th century. I guess it goes back into the 20th century, but it was really the wonder drug, right? Like you couldn't turn on your TV at some point without seeing Viagra commercials. Now it's a little less common than that, and it's like generic, and it's a lot. There's a lot more of it on the market, so you see a lot fewer of the commercials, but it is a medication that does essentially increase blood flow, which in turn increases the chances of having an erection for men. So it has been a wonder drug. It does have side effects, headaches, just flushing, things like that. And some people have such serious side effects that they discontinue. But for the majority of people who take it, they do see some positive results. And then, now we have other things as well. We have now Cialis, Levitra. Can't think if there are any more. These are all for men. Some are prescribed off-label for women. Viagra in particular there's some off-label prescription for women, but it's just more complicated for women, right? It's not strictly a blood flow issue. It can be that combined with like psychological components that are very strong. And it's just not as easy to treat in women as it is in men. There was a drug that was marketed and pulled off the market, back on the market. I don't know if it's still on the market or not for female sexual dysfunction, but just not that common or easy to get. So there are other things too, injecting medications similar to Viagra that increase blood flow, vasodilators directly into the penis. Obviously, that's not something that a lot of people want to do, so that's kind of a last resort. Testosterone therapies and treatments are common for men and women. Low testosterone, also things you hear a lot of commercials for. Prosthetics and implants, vascular surgery, replacing, veins and things like that. All different types of treatments that are out there. So there's that. So the next section we'll talk about is sort of the other disorders, the paraphilic disorders. And these are essentially misplaced sexual attraction or focus that generally tend to be on inappropriate objects or people. And often people have multiple paraphilias. There's high comorbidity with anxiety, mood disorders, and substance abuse. So there's often other things going on here as well. Some of the ones we'll talk about, some in various capacities. Fetishistic disorder, voyeurism and exhibitionism, frauderism, transvestism, sadism, masochism, and just pedophilic disorder. Paraphilic disorders in general manifest in fantasies, urges, arousals, or behaviors. They're not always disordered. Hence the conversation at the beginning, that many times, many of these things are just normal part of sexual behavior. They're not considered disordered in your particular situation or instance. They're just part of what you like sexually, and that is okay. The thing being here is that we consider it a disorder when it is clinically impairing and causes distressing enough symptoms. If you don't like it and you don't want to have these thoughts, or these thoughts are causing trouble, they're getting you arrested, they're getting you in trouble, or there are non-consenting people involved, then you have a disorder. Otherwise, just not it doesn't meet that criteria. So when we're talking about the differences. Easy for me to say. Fetishistic disorder, fetishes are sexual attraction to non-human objects, inanimate objects, tactile sensations. Some examples that you commonly hear are fetishes of rubber or hair, latex, rubber, hair, feet, shoes, just about any sort of inanimate object people can develop a fetish for. We generally hear about things like foot fetishes or leather fetishes or, things like that. So we're talking about here, and these are long-term, again, not just like in one particular setting. You thought that was kind of cool. These are things that you require in order to be aroused. And there is also part of the problem when we're talking about this. You can't get aroused without having these things. And that's what leads it to being more of a disorder than not a disorder. So the DSM criteria, and I'll read this is the first one. Over a period of 6 months, recurrent intense sexual arousal from the use of non-living objects or highly specific focus on non-genital body parts manifest by fantasies, urges, or behaviors. The fantasies, sexual urges, or behaviors cause clinically significant distress or impairment in social, occupational, or other areas of functioning. And the fetish objects are not limited to articles of clothing used in cross-dressing or transvestic disorder, or devices specifically designed for purpose of tactile genital stimulation. You can't have a fetish for a vibrator. That's the intent of the vibrator, is to be used as a sexual object and to create stimulation. That they can't count. So a non-sexual object is what we're talking about. Frotteuristic disorder is persistent gratification from rubbing it up against someone who is not willing. This often occurs in crowds or places where it's hard to escape from, subways or buses, or like other really crowded places like music concerts or things where there are going to be a ton of people and it's going to be hard to know, and you're not going to be sure whether someone did something by accident or they grabbed you or brushed up against you by accident, or if it was intentional, and they can get away easily. That's usually where you see this. Again, it's a non-consenting sexual arousal from touching or rubbing up against a non-consenting person. Quite honestly, the thrill wouldn't be there, the urge wouldn't be there if it were a consenting person. That's part of the fantasy here, is that the person doesn't want that. It's a couple you've heard of: voyeurism and exhibitionism. Voyeurism is observing an unsuspecting person undressing, naked, or engaged in sexual activities, or peeping toms. Also, the risk associated with that is thrilling and can cause some sexual arousal. So the people who enjoy watching other people having sex or undressing. Often people will be seen putting cameras in bathrooms or dressing rooms, or watching people through windows. So that's generally voyeurism. Exhibitionism is people who get arousal by exposing themselves to strangers, unwilling people, or the thrill of having people watch them have sex. And that thrill is necessary for them to have sexual arousal. So generally they're only going to get excited sexually if one of these things is happening. I'm going to start going faster because I can tell I'm losing my voice. So again, this is 6-month period. Transvestic disorder, a little controversial, probably won't make it to DSM-6 whenever that comes out, but sexual arousal with the act of cross-dressing. Males may show highly masculine compensatory behaviors, but most do not. Many of these men are married, and this behavior is known to spouse. It is not inherently pathological, only considered to be a disorder if it causes distress and impairment. So the act of cross-dressing, transvestism, is not a disorder unless it causes clinically significant impairment and impairs with a person's life. Unless they find it distressing or it's causing them problems at work, or they're going to lose their job or whatever, that's the only time we're considering this to be a actual disorder. And it goes over the period of 6 months, so it's a long-term kind of thing. And then we'll get into just kind of briefly sexual sadism, the sexual arousal or gratification that comes from inflicting pain or humiliation. And masochism, the arousal or gratification comes from receiving pain or someone else inflicting that on you. This is something that occurs, again, long-term. It's recurrent and intense sexual arousal from either of those things, receiving or inflicting pain on another. And also in terms of disorder, this person has acted on these urges with a non-consenting person, or the urges and fantasies are causing significant impairment. So again, when does that, which is a part of BDSM, which has become much more mainstream in the last probably 10 years, when is that a disorder and when is it just part of, a normal sexual behavior? Non-consenting people, and or it causes significant impairment. Anytime there's non-consenting people, it's disordered behavior. Anytime anyone non-consenting is involved, it becomes disordered. It falls under the category. But if it's causing you a lot of distress, you're really upset about it, you would like to control it, but you can't, that also falls under the category of disorder. And if it's causing you a lot of problems. So remember, keep that in mind when we're talking about this. And then pedophilic disorder, the sexual attraction to prepubescent children. The vast majority of these folks are male. It's rare, but not unheard of in females. In some cases, this is limited to like incestuous behavior, but not always. And many people don't actually act on the desire. They just have the pedophilic desire without the behavior, but often engage in some sort of compensatory behavior, like to make up for it. Like people who have pedophilic disorders will often lead themselves towards fields that put them around children in a helping way, at least in their mind. So like camp counselors or Sunday school teachers or things like that. I'm not saying that all camp counselors or Sunday school teachers are pedophiles, because that is definitely not true. What I'm saying is that they would be more interested in those types of positions because they put them, it's a compensatory behavior. They can help work through some of these fantasies by making up for it by helping kids. Hopefully that makes sense to you, but we're compensating for these thoughts in our head by trying to make good on that. But often that becomes too much and can lead people to engaging in some of these thoughts, and it makes it harder to sort of prevent. To them, it makes it, you putting yourself like an alcoholic working at a bar. It's going to be very, very difficult to maintain. In terms of some of the features, incestuous males may be aroused by adult women, but generally male pedophiles are not. So there is a difference with sort of incestuous behavior, but generally pedophiles are only aroused by children and not by adults. Some people even rationalize the behavior, like they consider affection or teaching or other things such as that. And again, with some of that compensatory behavior, they're trying to help, which is a very, very disordered way to look at it, but it's very, very common. They often have difficulty forming normal relationships and have problems with, they couldn't have a normal sexual relationship with an adult woman. It just would not work, and it would be problematic. And often they have very high sex drives as well. So that just sort of furthers the problem. In terms of treatment, not a great treatment, to be honest. We generally focus on behavioral treatments, sort of looking at the inappropriate sensations, doing things like covert sensitization, where you're imagining aversive things, aversive consequences, while looking at like pornographic images, for example, trying to create this negative association between the thoughts and feelings you have with the potential consequences. It isn't terribly effective. Family therapy, marital therapy, addressing those interpersonal issues are something that you'll sometimes see. And then just relapse prevention, trying to manage sort of risk long term, is something that you focus on. And, they have sex offender reentry treatments, and your textbook talks about some of those and how they show 75, 95% effectiveness in terms of some improvement. This doesn't eliminate or make these impulses go away. There's just some improvement. So how long-term that is, or how that goes once treatment is gone, I think still remains to be seen. There is a high rate of relapse, and the poorest rates of recovery are with people who have multiple paraphilias or have engaged in sexual assault or rape. There's also some medication that is used, effectively chemical castration, giving people medications to kill their sex drive. Again, this is not super helpful because of discontinuation. People, if they want to, they can stop. And once you discontinue, the sex drive essentially returns. So again, just problematic in many different ways. And I'll kind of mention this next section and then we'll wrap it up, but we're talking, also included in this section is gender dysphoria, this feeling that you're trapped inside of the wrong body, inside of the wrong sex. So you're born a woman and you feel like you're trapped inside of the woman's body, but you feel like you should be a man. And that is how we refer to gender dysphoria, this desire to assume the identity of the desired sex is different than the sex you were born with. And the goal is not sexual in nature. So it isn't a attractiveness towards one sex or other. It has nothing to do with it. It's just feeling like you are not the gender that you were born. Causes are unclear, but it usually develops between 18 months and 3 years of age. Gender identity, and it is fluid gender identity, or cross-gendered identity is not particularly a disorder. It's only a disorder when it becomes distressing. So there's often this incongruence with children with gender, and up until a certain age, gender identity can be kind of fluid. But once you are feeling this discomfort about not feeling like you fit in with whatever gender you are, that's when we start running into problems and seeing kids who have gender identity disorder. And that's what we're talking about here. So this incongruence between one's expressed gender and the assigned gender ongoing. This is not a short-term thing. So at least 6 months, with desire to be the other gender, in boys, strong preference for cross-dressing, and girls, preference for wearing more traditionally masculine clothes, and preference for cross-gender roles and make-believe or fantasy play, preference for toys, games, activities of another gender, preference for playmates of the other gender, and strong dislike of your anatomy and a preference for the other gender's anatomy. So, you can kind of get the idea as we're going through here, some of the problems that you're looking at. Looks a little different in adolescence. Again, it's a long-term thing, but this incongruence between your expressed gender and sex characteristics, desire to get rid of your gender or your sex because of this incongruence, and a preference for the other. Again, a strong desire to be, if you're born a male, strong desire to be a female and vice versa. So in terms of treatment, there is gender reassignment surgery. 75% or so are reported to be satisfied. you have to go through a lot to get that. You have to be psychologically fit, financially stable. It isn't cheap. Female to male conversions tend to fare better. And let's see, what else I want to say. Often, like with if you're born with both sex organs intersex, often this treatment happens at birth, and subsequent gender dysphoria may develop. So that can be really complicated. Sexual dysfunctions among folks with, well, no, we're skipping ahead. So let's just kind of wrap it up there. You can go down through. If you have any questions, you can email me. We went through this kind of fast, but I still have a voice and it's over. I will post some more stuff as the week goes on in terms of assignments for the week and information about the test, but I'll get that to you as soon as I can. Hope you all are doing well. And as always, if there are any questions or comments, just feel free to let me know. I will see you next week.